Hello, everyone, and welcome once again to the Pearls Lecture Series of 2023. My name is Bilal Hafiz. I am a third-year medical student at the University of Melbourne. And before we get started with our talk today, and I introduce our speaker, I wanted to quickly talk about Pearls as an organization. So Pearls stands for POCUS, for Emergency and Acute Care in Resource-Limited Settings. And it kind of stemmed from a program that started last year. So in August, the inaugural Pearls course was first run in Port Vila in Vanuatu, where Vanuatu physicians received handheld ultrasound probes to plug into their smartphones. And they undertook 3 days of vigorous ultrasound training from a team of visiting Australasian team that consisted of ED physicians, as well as sonographers, including the lead of the POCUS Pearls program himself, Dr. John O'Henry. Now, after the course was completed, these upskilled physicians, they continued to receive feedback via remote imaging. And since then, the Pearls Lecture Series was also put into play so that we can continue on supporting these physicians from the resource-limited settings and keep supporting them in their emergency as well as their acute healthcare provisions. So today, we'll start off our fifth lecture of the year with the FASH ultrasound given to us by Dr. Heller. So we know I've already emailed you all about Dr. Heller's background, but we'd love to hear from him some insights on his training and his focus within his emergency practice and some of the things that he's learned over the years. So perhaps before you start your talk, Dr. Heller, you can tell us a little bit more about how you got into ultrasound, how you've made it a big part of your practice, and how you use it today.
Yeah, yes, super, of course. Thank you. And thank you, first of all, for the invite. It's a pleasure. And I love the idea that you spread the word, spread the word of the point of care ultrasound. And I'm happy to give you an overview of as you might have seen, I'm not an emergency physician. So, and I'm an internal medicine physician from Germany. And it just happens that in Germany, the setup of ultrasound is a little bit different. So basically, ultrasound is a clinical tool. So it has always been more or less localized in the internal medicine department, in the gynecology, in the pediatrics. So the radiologists, and my theory is that they are much more happy to write bills for quick X-rays than to sit 10 minutes with a patient and then they can only have a small bill. So the radiologists were never terribly interested in ultrasound in Germany. It was always a clinical discipline. So from when I started in general internal medicine, there was you used ultrasound. And I think that's a great opportunity that we have as German physicians, because basically you can get to the depth of ultrasound that you find helpful for your practice. I mean, some of the primary health physicians will do very limited ultrasound. Some of the gastroenterologists will then go into the depth of the biliary tract, I don't know, so that there is this liberty to use the ultrasound, and obviously it is also very much used in Germany, and that's also one of my focuses. It's used in guiding interventions, right? So and then because I worked, so maybe I don't know how much of my CV was there. So I trained in Germany, then I left Germany. Well, I worked a couple of years in Saudi Arabia in an ICU, and then in infectious disease. And then I moved to South Africa, working mainly in infectious disease, HIV, TB. There I will show you some slides. And since that time, I prefer, I would say I prefer to work in resource limited settings, because I don't know, I prefer it. I don't know why. it's just it suits my way of medicine more than if it gets too high techy. And I think the idea of this presentation is to give you an idea on how we develop the FASH ultrasound and sonographic diagnostics, in particular in sub-Saharan Africa. But by no means this is limited to sub-Saharan Africa, because it is, I think, particularly a tool for, like you said, for any resource limit setting. And I know that you guys are excited about ultrasound. So usually I say, I hope I can get you as excited as these guys seeing the first tablet. But I would like to give you an idea how I am excited that like they are. If that's okay, I would start, and then maybe we can discuss.
Such precious insight, Dr. Heller. Thank you for that. Please take it away as you'd like to.
Yeah, so I mean, as you know, and I mean, here I'm preaching to the choir, ultrasound is a safe and effective form of imaging, and we used it for decades, as I said, for diagnosis and to guide procedures. And what has changed over the years, and I started doing ultrasound in 1996. So what has changed over the last 25 or whatever, 28 years, the equipment has certainly become much more compact, higher quality, and especially less expensive. So I show you this, I don't know how you call it. It's like a an oversized laptop machine, black and white machine that I use mainly in my work. It's a Chinese brand, which I will not name, but it is about, when I started, it was about $1,000 the machine and $1,000 the probe. I guess with the inflation, it's now maybe double the price, but it is still in the realm of a few $1,000s, and it is still in an area where you can say I use this as a private tool. And with this, and particularly, of course, with the handheld and the newer devices, the concept of the ultrasound stethoscope is rapidly moving from theory to reality. And that's, I think, why we meet now. With this ultrasound, with this democratization of ultrasound, I would say, came the concept of focus ultrasound. And in this one, I have to say I'm very grateful to the emergency medicine societies, particularly in America, who basically made this concept more and more clear, that you don't need to do all to be able to before you're allowed to grab the probe, but you need to know what you want to use your ultrasound for, and then you use it for that indication. And if you put up point of care ultrasound programs or protocols, they are usually based on binary questions. So it's a question we have that is clinically relevant to us, and then we say, hey, is it yes or is it no? Is there an effusion? Yes, then I will tap it, or I will give furosemide or whatever you do. Or it's not, then I think otherwise. And I think this is the main concept, that the questions need to be clear. And looking at the protocols, there is a few more points, and that is, whatever you look at, it should be prevalent in your setting. So I mean, and I always give the example that in most emergency medicine protocols, you will find somewhere this AAA abdominal aortic aneurysm finding. Yeah, it's a great tool to find aortic aneurysms. Frankly speaking, in my 7 years in Africa, I have seen 2. And it's absolutely not prevalent because of the age of the population. So so it's not really helpful in our setting. The problem is not prevalent. Then the next point is, it needs to be relevant for your therapeutic decisions. So I come back to the same example. I mean, even if I find this aortic aneurysms here in Malawi, we have no vascular surgeons. We have nothing to do. The only thing we can do is a syphilis test to see if it is a syphilis associated aneurysm, and then we give some penicillin. That's the only thing we have. So there is no therapeutic next steps. So, and if you have nothing to change, then why don't you want to look for it? And the last, and that is maybe why we are talking, it needs to be the findings need to be easy enough to be recognized confidentially by somebody who is not undergone 6 months full ultrasound training, where you sit in the ultrasound suite every day and you scan 10, 20 patients a day. No, it needs to be something that can be recognized confidentially by a mainly clinically working colleague. So these are the 3 characteristics that I think are essential to look at whenever you say, in my hospital, in my setting, I want to start to look for this. And then you want to ask yourself, is it prevalent, is it relevant, and is it easy enough? Good. And of course, FAST, you all know FAST. This is basically the bedrock of point of care ultrasound, this focused assessment of sonography for trauma. The term was coined in 1996 as an integrated goal-directed bedside examination. Sounds great. to detect free fluid, and because in a case of trauma, like in this picture here, and that's a German picture because the ultrasound is now getting out of the hospital and the pre-hospital ultrasound increasingly. And basically what you look for is free intraperitoneal fluid, pericardial fluid, pleural effusion, which in a setting of trauma might or heavily suggest that you have hemorrhage and that you need to alert the surgeons to be prepared to do something. And so when my wife and I came to South Africa, we knew, of course, very well about the FAST. Is this moving? Yeah. And we thought, what can FAST be in Africa? And this is definitely a FAST situation, and it's very life-threatening. So you have to do something quickly to save your patient. And yeah, so this could be definitely one application of FAST in Africa, but neither my wife nor I are running that fast. And luckily, most of our patients were also not terribly under threat from cheaters. So we thought of something slightly different. And we started with a problem, and this is the typical problem in KwaZulu-Natal. This is a 23-year-old HIV positive patient. She complains of loss of weight and night sweats, and she has cough for 3 weeks. And okay, the sputum acid fast stain at that time was negative. The urine alarm, it's a urine test for HIV, for TB, which is also negative. And you can see I don't know how experienced you guys are in treating TB or how many you see, but I mean, if you have somebody who's HIV positive, so he fits the profile, he fits the immunological profile, he has the clinical symptoms, he looks typically a bit wasted, and she is in an area where there is a lot of TB, then you think this is likely TB, because it is, despite the fact that the test actually is negative. So we put this patient in a special cough clinic, we called it. And then what we did is, for all of them, we did the HIV test. So that's how to know that they are HIV positive. And then we did a chest X-ray. And now this chest X-ray gives us something. It gives us a very, very thick and solid upper lobe pneumonia, which is infiltrate, which is very, very compatible with TB. Again, it's a pattern in the X-ray that is compatible with TB. So despite the fact that we had no laboratory confirmation, some people would say, well, I mean, this is so clear that I would even start TB treatment without any further investigations. Fine, happy with that. I would do that today. But at the same time, you wish to get a little bit more evidence, right? So and this chest X-ray gives you a bit of evidence because the pattern fits. Or if you take this one, you have a nice cavity on the right side. So this is a typical TB-ish pattern in the X-ray, which makes you more confident to say, I will start TB treatment. This is another one. And you see again, upper lobe cavity. This is typical pattern for TB. And this is maybe giving us, making us just more comfortable to say we have enough evidence to start to commit this patient to 6 months anti-TB treatment. Now, if you look at the well, that is almost, that are very, very good but very old 2007 WHO guidelines on improving the diagnosis and treatment of smear-negative pulmonary and extrapulmonary TB amongst adult and adolescents. So in HIV settings, there you find a really good table, in my opinion, with the 5 most relevant forms of extrapulmonary TB. There is lymph node tuberculosis, peripheral lymph nodes. We might talk about that a little later. You find on the other side, you find the TB meningitis, and that's the one thing where up to now the ultrasound cannot really help us very much. But then there are 2 forms. There is the pleural effusion and pleural ultrasound. So it says unilateral effusion is very compatible with tuberculosis, extrapulmonary tuberculosis. And then you see there is the pericardial effusion, which even says you should do a cardiac ultrasound, cardiomegaly, and then this is very, very compatible and suggestive of pericardial TB. And then these are indications in a way to start TB treatment. And of course, you can already see now pleural effusion, pericardial effusion. You see the connection with a FAST scan, right? So we said, okay, maybe we can repurpose. But then in the middle, there is this disseminated tuberculosis, and that is maybe where I want to talk a few minutes more. But okay, sorry, before we come to that, I just a quick reminder, how does the pleural effusion look? I'm sure you all know. So in the X-ray, we have this opacity, which is pretty solid. We have, and then we have the air, which is dark, the effusion, which is white. And if we do an ultrasound, we see, I think this is the other side because this is the spleen, but we see the diaphragm. And above the diaphragm, we see this, in this case, liquid black fluid with multiple fibrinose septa and septa and fibrin and sloth. So this is a very exudative effusion, and this is very compatible with TB. It's not the only thing that causes this type of effusion, but it is a pattern that is highly compatible. And the same is true for the infiltrates, which we see. Not TB is not the only thing that causes cavities, but it is very compatible with. So it gives us a little bit more evidence. How does the pericardial effusion look? Well, on the X-ray, of course, you know, it looks like a cardiomegaly. That's and it's very difficult from this X-ray to know if you're looking at a failing left ventricle, at a cor pulmonale, at we have a lot of we also still have a lot of rheumatic heart disease, or whether it is a pericardial effusion. But the ultrasound, and I mean, I put up here a normal beating Malawian heart, and then down here you see this heart. So, and you see the black, again, the black fluid is the giveaway, and you know this is a pericardial effusion. And then it narrows your differential significantly, and if the rest fits, then this is a good indication to say I start TB treatment. Good. Now, let's come to the middle, and that brings me back to KwaZulu-Natal. This is another 23-year-old HIV-positive patient, and she also complains of loss of weight and night sweats. And but she additionally has some mild abdominal pains and hiccups, and sputum AFB is negative. So again, no proof of TB for the nurse to start treatment. We did a chest X-ray, and there is nothing really that is clearly suggestive. It's just, well, there is nothing. So what we did with these patients, we basically took them for ultrasound, and these are the ones in the middle now. So, and before I show you the video, I just want to let's start. Oops, we're going backwards. So we took them for ultrasound, and what you find what we found very repetitively, almost to the extent of saying this got boring, is this picture in the upper abdomen. You can see there is the liver up here, right, which we use as an acoustic window. In the distance here, you can see the spine, which gives you an idea that the size of the image is well chosen. And in the middle, you see this hypoechoic roundish things which seem to change in size as we fan the transducer up and down. So obviously that are roundish things, because if you go back to this one, if you have a round ball and you look at the round ball with an ultrasound, which gives you slices, you will get small slices in the beginning. And then the slices get bigger, and then they get smaller, and then the thing disappears. So that is what happens when you scan over a roundish little thing. And obviously the most common roundish little hypoechoic thing in the abdomen, especially when multiple, are lymph nodes. So these are, I don't know, 20, 30 enlarged lymph nodes. The size is somewhere 2 centimeters in the short axis, maybe, but let's say larger than 1.5 centimeters. And they are certainly a pattern. And of course, the pattern, again, you see where I'm getting at. This pattern is very, enlarged lymph nodes are very suggestive of TB. if you have no other good explanation. It's not the diagnosis of TB, but it is a suggestion of TB. So here's another example. Again, you see the upper abdomen transverse scan. You see there's the window. You see a little bit of more echogenic pancreas here. But then there is also multiple roundish structures. And just for the sake of this blinking, because for me it's always most important to stress on that lymph, because the lymph nodes are blinking. They are getting bigger, smaller, getting bigger, smaller. If you compare this here to the IVC, which obviously is a tube, as you pass your transducer up and down, it is staying a tube. The size doesn't change significantly. It maybe get a little bit smaller, but not much. So this is the difference. If I scan a tube, it stays. If I scan a ball, it gets bigger and smaller. It does this blinking thing. Hope that makes sense. So this is, again, a similar case, massive upper abdominal lymphadenopathy. What we did then is we moved the transducer to the spleen. And in the spleen, we find this picture. This is obviously the spleen, right? Here you can see this bean-shaped organ. You see there is something nodular down here. I don't know, is that a lymph node? Is it an accessory spleen? I don't know. If this is the only one, I would call it an accessory spleen. And now, but I want you to look at the splenic tissue, and I want you to tell me honest, you can put it in the chat. Do you think this tissue is smooth? Is it homogeneous? Let's see the chat, if I can see the chat. Because I want to see if anybody is still awake or if everybody is fell asleep. No, sorry, I didn't put the question here. Do you think it is? Do you think this is homogeneous? Not heterogeneous? I don't think it's. No, I don't think it's homogeneous. No, not homogeneous. Okay, it's not completely homogeneous, and that one I agree. And I never seen this video on the other side of a Zoom call, but you might think and you might see that there are areas which are a little bit darker, right? So here is a little bit darker than the rest. But, and for those of you who said no, in a sense of it is not heterogeneous, I don't blame you, because this is not very marked. And I would not, you remember my beginning, I said it needs to be reasonably easy to recognize. And I think to determine whether this is homogeneous or not is not reasonably easy. But luckily, technology helps us because we have linear probes. So what we do is, for the spleen, we always use a linear probe. And this is the same spleen. So now I'm asking you, do you see the roundish, blinking, dark lesions? And I'm pretty sure. No, I don't think our ultrasound machine has chroma maps. We are pretty. It's limited. But you see, the trick is to use the right probe. So the spleen is generally, particularly in a skinny person, a pretty superficial organ. So you reach it with your linear probe. I mean, if you see here, we are in 2 to 4 centimeters. We have already the spleen tissue that we want, and I think everybody agrees that there are hypoechoic about, I would say, 0.5 to 1 centimeter lesions, hypoechoic, which are a pattern. And this pattern at that time wasn't very well described. So I show you this one. It's another convex probe. And you see the spleen is a little bit more enlarged, and you wonder again, is it normal or is it not? And I don't know, the spleenologist amongst you might say, this looks not quite velvety as a normal spleen tissue does. But again, it's also not terribly strange. But the moment you put the linear probe, you see that there are millions of hypoechoic lesions throughout the spleen, which create this abnormal echo texture. And these are again the same hypoechoic lesions which are throughout the spleen. It's basically miliary TB mirrored on a spleen, because I mean, a miliary pattern is usually white dots on your X-ray. and now you have black dots in your spleen. So it is the micro abscesses. So what we did then is at that time we didn't have much study money because we were basically practitioners and not researchers. And what we did is we just made an ultrasound definition. We said anybody with lymph nodes enlargement bigger than 1.5 centimeter and or these focal spleen lesions, and we can we can look for ascites just to make the FAST complete for further supportive evidence. And then we screened 180 HIV positive adults, and 17% had this ultrasound case definition. So these were HIV positive adults pretty advanced, as you can see, with a median CD4 count of 78 cells, pretty much wasted because the BMI was below 20. And a lot of them had advanced or even very advanced HIV disease. So what we did is we put all these 30 patients on a TB treatment, and then we just followed them, and we put them at the same time on ART treatment because extrapulmonary TB was, according to guidelines at that time, also a reason to start ART. And then because of limited resources, our follow-up mechanism was just the TB coordinator to follow them all up. And after an average median of 17 weeks, we called them, 25 patients were reached. It's not ideal, but anyway. And then we found this 19 patients were still taking their tablets and reported clinical improvement and said, thank you, you did the right thing. And 6 patients, and that's 24%, had died. So now the question at that time was, well, what do you make of this result? Is it good or is it bad? And I think it depends. I mean, if I'm talking to university hospital and I say you get your diagnosis and 76% right, they would probably say we aren't that bad. But if you work in a really remote setting where your resources are very limited, you don't have many tests, and you get your diagnosis and 76% right, you probably feel that's quite good. So we said it is good enough for us to continue with this, especially as we are not sure. I mean, disseminated TB in an HIV positive advanced HIV disease patients in itself, still, if you put them on treatment, it carries some mortality. So maybe even some of these patients might have been treated correctly, but we were just too late. But anyway, it is not it's not a very hard science study, but it was enough at that time to give us a bit of confidence to follow that. And then, of course, we said from Africa, there has to be always something new. And what we did is we just changed the protocol. And obviously, we couldn't say we do focused assessment with sonography for TB, because then it would be fast again and nobody would know the difference. So what we said is we do it for HIV-associated TB, and so it became FASH. And what you see is just the same 6 views with which we used in the FAST scan, with added on abdominal lymph nodes in the view 1 and focal spleen lesions in the view 4 or 5, whichever you 5 actually. And at that time we added also some liver lesions, but honestly speaking, over time we found that you do not have liver lesions without having spleen lesions. It's very, very rare, and it makes the teaching of the protocol so much easier if you just focus on abdominal lymph nodes and spleen plus the effusions. Cool. So then the next question was, can we teach this to clinicians? And in 2010, we did a training course, which is probably very similar to the courses that you do when you go somewhere. It was basically a weekend course for the residents. We trained them in the basics of physics, and then a little bit in the basics of the diseases, and then we just trained them to recognize the pattern of pleural effusion, pericardial effusion, ascites, lymph nodes, and spleen. And they were performing after a couple of weeks. They continued a couple of weeks doing their own thing, and then we had a second follow-up testing, and they were quite good to recognize these things, which is in line with what we know today about teachability of ultrasound modules. One point we looked at later in the course, after colleagues from Italy had reported similar, and we convinced people from Saudi Arabia to look at the same thing. And so we wanted to know, remember in the beginning, we were starting with an X-ray, to do an X-ray, and we wanted to know how many actually profit from this beyond having the X-ray. And so what you see is, 2 things there. First of all, a lot of the chest X-ray, about 21%, actually have miliary TB, which is compatible with what we think, right? Because we said this is a miliary pattern, so they also, these 20%, obviously we could also have diagnosed by doing a chest X-ray. But what was more interesting for us is that 22 of 82, and that is about a quarter, had no, in the chest X-ray, had no findings which were suggestive for a non-radiologist for TB. So because that's where actually most of X-rays are read in our setting, right? It's clinician holding it against the sun, or if he has a light box, even better. But that's the point where that most of them had no obvious signs. So that made us even more convinced that we have a significant proportion of patients which we can diagnose by ultrasound, which have no significant X-ray changes. Good. Over the years, FASH became fashionable, and you see more and more, and this is not myself, this is an article from Malawi, this is in pediatricians, Rwanda had published something there. This is from Indian patients. So there are a couple of populations who found that this principle is applicable in their populations as well, which does not come as a big surprise because it's more the HIV and the TB, not the population. And the nice thing is, in the meantime, some real researchers, particularly from the Cape Town area, have looked at the FASH protocol, and this is a good study now, and I just cite one. There are a couple. Now they looked at 377 inpatients with suspected TB in the Cape Town area, and again they took HIV positive patients who were pretty sick, so they had more than one WHO danger sign, and were most of them being unable to walk. So these are pretty sick clients. They looked at them with the 2 probes, and then they ran the full battery of tuberculosis tests that they could get on them. And then you can see here, and I will focus now on the odds ratio, the adjusted shows similar things. The enlarged lymph nodes are associated with the end final diagnosis of TB. The spleen hypoechoic lesions are significantly associated. The splenic enlargement, which is one thing that the WHO guideline suggests, is actually not significantly associated after correction. And effusions are also associated. Probably effusions are less solid or less predictive than the lymph nodes and the spleen lesions. Luckily, this led to the fact that FASH is now part at least in Malawi, it is a recognized diagnostic way in our national guidelines, which makes it easy to negotiate that you get TB drugs for your patients when you find the suitable signs. Cool. At this point, do we have any? I'm at half an hour now. Do we have any burning questions already, or anything people want to comment? Otherwise, I would continue. Okay. In this case, let me continue. Okay, I now want to look at lymph node TB, and this is a typical patient here at Lighthouse with swollen lymph nodes, likely HIV positive, but can also be HIV negative. And what we do here is basically we want to diagnose the TB, right? There are other explanations, and I think everybody in working in a low resource high TB setting knows what you do. You stick a needle in and you aspirate, and then you look for the TB bacteria. But it's interesting that even amongst our normally pretty invasive clinicians here, sticking a needle into a neck is not necessarily what you do, because you have this remembrance of anatomy that there are some big vessels which you don't want to better prick. So it's not commonly done, honestly speaking, the lymph node aspiration. But since we use the ultrasound, it is much more common that it's done. So here is here's a video. You see it's the same principle. You just put a needle, you put a syringe on, and then you basically put suction and put a vacuum into the syringe, and then you just go This is the lymph node here, and you just go into the lymph nodes, and you sample maybe 4 or 5 times. You sample cell material, and then you take it out. So this is, of course, a single loop. So we don't do this 25 times. To do it 4 or 5 times, and use a needle that is sufficiently big. Like, for example, we use usually a green cannula, obviously without the part of the plastic part. We just use the needle of the green cannula, and that is good for sampling cell material. And when you then you take what we have a lot is this gene expert machines for TB diagnosis. So you take 1 cc of normal saline or of distilled water, and you just flush the material in. And what you get is not really, you don't get anything out. You just get this, after flushing out the needle, you get this turbid material, and you get this turbid fluid, and that's exactly what you want for your gene expert. And it's very often that this is expert positive then, if you put it in. Good, so that's a comment on lymph node, on lymph node TB. Just a second. Okay, no, it's fine. But now I want to expand a little bit into other areas. So this is a 24-year-old man presenting with dry cough, night sweats, weight loss. Again, typically we are thinking of TB, and we're looking at the chest X-ray, and I don't know if you can see it. If you look more carefully, you might see that there is this velvety, tiny little nodule. So this is actually a case of miliary TB, which is fitting with his very low CD4 count, and in a way we could start TB treatment. But because a lot of people are nowadays interested in lung ultrasound, we scanned this patient, and you see this is the pattern that you see in miliary lungs. So it's basically an interstitial pattern with B lines and these tiny little granulars, just nodules, subpleural, tiny. So that's the pattern that you see in miliary TB in the lung. Good. And now I want to come to a very important point, because so this is a last case, I think. This is a 13-year-old female I saw here in Malawi. It was actually seen in another clinic 1 month ago, and she was clinically diagnosed with TB because she had fever, night sweats, weight loss, back pain, and she had a positive FASH. Sounds good. I mean, sounds like what we just said is correct. The problem, she returned to the clinic with worsening symptoms after a month. And so when the colleague called me, I said, well, why don't you bring her over and we scan her together? And this is her spleen. And you can see, this is what I just showed you, right? These are, oh, sorry, this is not looping. These are hypoechoic multiple lesions in the spleen. That's just what we said. So point 1 is, box 1 is ticked, so the clinician did the right thing. We looked at the upper abdomen, and we see again the liver, and then you see these growing and shrinking lesions, roundish lesions. These are enlarged lymph nodes. So the clinician was absolutely right. But it's maybe not 100% fitting. In the very beginning of the clip, you see that there are also some really big lesions in the liver, which are not so fitting. But we didn't say that there is an, after you looked at the spleen, look at the liver, and then, no, it is not like that. So in a way, it was correct to start her on TB treatment because it is the most likely diagnosis. But it's not the only diagnosis. So basically, what we did for this young lady, we did a biopsy of the lymph nodes now, and it turned out to be a lymphoma. So what is, and this is, I think, kind of important, is what do we expect from FASH, with the FASH findings to happen? And most of the lesions disappear in 1 to 3 months. And mostly when you put patients on efficient TB treatment, they improve in 1 to 3 months clinically. So if they do not improve or even get worse, then you have to reconsider. And if you have a TB patient who's not getting better, you want to check, is it a compliance problem? Is she not taking her tablets? But she said she is taking her tablets. Is there resistance? Well, luckily in Malawi, we don't have much problem with MDR TB, so it was unlikely. Is it iris? Can it be that there is, due to the due to the ART we started, that this causes it, or is it an alternative diagnosis? And of course, if you have treatment for lymphoma, then this is relevant. I mean, in South Africa, it was less relevant because we didn't have anything to offer to the patient at that time, but to HIV-associated lymphomas. But here in Malawi, we have next to our clinic, we have a very good cancer program. So it was relevant to find. It is more relevant to find that. Good. And so I think what I want to point, and this is my last slides, what I want to say is you need to put the technology at the right place. This is a traffic risk reduction program 2 kilometers before Mavini Clinic on my way to the hospital in South Africa. And you see this lollipop lady. She works perfectly fine. All the children behave. And if you go 8 kilometers on, if you put the traffic risk reduction at the right place, then even the little elephants, they obey and they cross the road exactly where you put the sign. If you put the sign at the right place, and that's where the elephants cross. So I think that's the end of my presentation. Just a final word, in case somebody happens, I know you are very far away, but in case you happen to be in May in Europe, there is this course in Italy, which we put together on short course on ultrasound and infectious disease and tropical medicine. If you want to come for the ultrasound, it's great. If you want to, there are other good reasons for Italy in May. And with this one, I just want to stop.